It is estimated that over 190 million women are affected by endometriosis worldwide. And what was once a condition that wasn't really talked about is gaining much more awareness. And as a result, we're having more patients come through asking questions about it and wanting to have conversations about it. So on this episode of Clinical Communication, I'm joined by Pauline-Clare Callaghan, who is not only a specialist pelvic health physio, but she's also a volunteer educator with Endometriosis UK. And on this episode, we're covering some of the common questions that may come up with endometriosis and how to discuss them, from diagnosis and explaining what it is, through to treatment, both surgical and non-invasive options. If you find this useful, please do go and share it with others. Please do subscribe. You can find me across social media at BYBrowPhysio. If you have any questions or queries regarding further support around communication skills, you can send it into clinicalcommunication@outlook.com. Thank you as always for watching or listening, and I'll speak to you soon. It's still quite delicate, isn't
Yeah,
it, for the surgery?
it's very delicate because women will often get MRI reports or they've gone for transvaginal ultrasound scans and they are aware that they get the report. Endo patients are kind of unique in the fact that they really they are very social media savvy. There's a lot of support groups and they will often post their MRI results to be interpreted, which is dubious in itself
Oh,
on
really?
these social media sites, mostly Facebook. And but they'll read that their pouch of Douglas is obliterated, so that's the rectal vaginal space. They'll read that their pelvic sidewall, their left ovary is stuck on the pelvic sidewall, the right ovary is stuck very deep within the rectum, and yeah, that can cause a lot of alarm with patients. And what I see with a lot of the endometriosis patient is they feel they have to be an endo warrior, they have to fight the system. And a lot of that comes from the fact that the reality is the from initial presentation to GP to getting a diagnosis, the average time in the UK is 8 years, 10
8
months.
years. Wow.
That's atrocious. That's an awful lot, many years of a woman doubting herself, experience quite significant cyclical pain, which often then becomes constant pain. And yeah, I mean, it's not the case with everyone. Some women are get a diagnosis sooner.
That's an interesting topic, actually, because 8 years, and as you said, they're very social media savvy, so they can, it sounds like they are, and they can find out this information. If they were to ask us, does this take so long for me to get this diagnosis? And putting waiting list times to one side,
I think it's hard to put waiting list at times aside. There are not enough specialist
mm,
BSG centres
mm,
with real endometriosis excision surgeons. And as I said before, there's a lot of postcode lottery that
mm,
goes on with these women. But back to the social media, it can be positive and negative. For some women, they find great support from each other, that peer support, but sometimes it can be quite negative. And a lot of the posts on Instagram, endometriosis is the most painful condition you can ever experience. And what is that doing to the patient's nervous
yeah,
system when they're
yeah,
reading that? And the people that are staying on some of these Facebook groups, they are not having a great time. Whereas the ones who are living well with their condition, don't feel the need to constantly post. And some of the posts are heartbreaking, what some of
really.
the women are going through.
Well, you said there's very few specialists, really
Specialist centres.
specialist centres. Um, and do we know why? Because you said there wasn't many surgeons either, is that right?
So there's big centres that are specialist centres that just take mostly stage 3 and 4 endometriosis. So that's the deep infiltrating endometriosis that are much more complex. So that's bladder and bowel infiltration. So they often need an MDT.
Mm.
So that's where there's a colorectal surgeon, a urological surgeon, maybe to do a cardiothoracic surgeon if they have extra pelvic endometriosis. So endometriosis just is not just a people used to think of endometriosis as a reproductive disease. But in fact, the very definition of endometriosis is that there are endometriosal glands and stroma and tissues. That's the endometrial-like, but distinct from the endometrial lining in the womb that is outside of the womb. So it can cause fibrosis, adhesions, and an awful lot of pain and inflammation.
Mm.
And endometriosis presentation is very varied. So for some women, they will have purely pelvic pain and it will be cyclical pelvic pain. For others, they'll have a lot of bloating, fatigue, painful bowel movements, painful urination, difficulty getting pregnant, heavy bleeding, pain with sex. The presentation of endometriosis is complex, and sometimes I think that can add to the difficulty of getting a definitive diagnosis.
People get this diagnosis, and as you say, you hear all sorts of stuff on social media, right?
Yep,
You can read all sorts of things, you can see all sorts of stuff. But not everyone does that, and their experience will vary from clinician to clinician that they see.
yep,
I think the first thing I think everyone will want to know is this person's been given this label of endometriosis. They may have been given a leaflet or told, "Yep, you've got this," and it may have been a case of they get the diagnosis but they're still trying to process it. That the person they've seen who's done the diagnosis may have said some stuff, but it's just not been taken in. And they turn round to whether it's you or whoever is with them and say, "What is it? Where do we start with that? If someone asks you, what is this endometriosis I've got? Why, what is it?"
So endometriosis is a chronic systemic inflammatory condition where the lining of the womb, the endometrium-like cells, are present outside the womb itself. So it causes fibrosis, adhesions, inflammation, and a lot of pain, and can affect fertility.
If they say, "Why me? Why has this happened to me?"
I don't tend to get the why me
How do you know? No.
particularly often. I get more about, what has caused this, what are they want facts. And truly the exact cause of endometriosis is still unknown. There are many theories, such as embryonic cell development, retrograde menstruation, metaplasia, whether it's lymphatic spread, hormonal imbalance, immune response, genetic predisposition. There are lots of theories, but no certainties. And I think for many endometriosis patients, sometimes you do just have to sit in the mud as
Yeah.
with them, as you said, and I've heard you talk about the golden minute, without interruptions, and I'm absolutely convinced the more and more I've worked with endometriosis patients is they don't need a golden minute, they need a golden 10.
Mm.
They need you to listen for a good 10 minutes without interruption, because then you get a really good understanding of their knowledge of the condition and what they believe is broken is broken, what they believe is the cause and how that is affecting them. And very often I will hear underneath during that golden 10 is that they feel broken, they feel their bodies betrayed them.
Mm.
And that belief alone will increase that pain experience. Sometimes they just feel overwhelmed and a sense of shame, and there is real fear for the future, and fear for their future fertility, fear that their pain is going to become unmanageable. Yeah.
Yeah, something it sounds like a lot of, if I can phrase this right, a lot of uncertainty. You said about fear of yeah, as you say, what will be the future? How is this going to affect me? Um, and you were even saying earlier about the different types of endometriosis as well. Do we know if the causes are unknown, or it's still lots of theories? If they were to ask, why have I got this type, but my friend's got this type, or these other people online, they've got this type, and it's affecting them in different way. Can we say any way, any why it affects others differently in different ways?
I think that's in some ways the paradox of endometriosis, and a lot of it comes down to the staging. So there are, within endometriosis, there's stage 1 to 4.
Mm.
So stage 1 tends to be your minimal, superficial peritoneal disease, up to stage 4, which is your deep infiltrating endometriosis, usually bladder and bowel endometriosis that has invaded the lumen more than 5 millimeters. So that's very complex. It needs your multidisciplinary team involvement to properly excise the disease. You don't want to ablate the surface. And but I think the paradox I was talking about is a woman can have stage 1 and have very, very severe pain, and another woman can have objective stage 4, but not as much pain. And so the stages don't equate to the pain experience, and that can be complex for patients to understand. Yeah, and the subtypes that I mentioned earlier
Mm.
can also coexist. So you can have
Mm.
the endometriomas, so your chocolate cysts on the ovaries, as well as deep infiltrating bowel endometriosis at the
Mm.
same time. So
Is
it's
it?
complex.
Well, yeah. I'm thinking of what you're saying, that people can have the different stages. I mean, even if someone's in stage 3 or 4,
Yep.
it sounds like from what you were saying that it doesn't necessarily mean they're going to be in as much pain or what compared to someone who's maybe in stage 1.
Yes.
Um,
And it doesn't progress. It's not necessarily that stage 1, you can live with stage 1 and that's all you will have, even without excision. It won't progress to that deep infiltrating stage 4.
yeah. Is there,
Truly
because
complex.
I'm thinking of the back pain example. Everyone brings up the classic back pain study where they get up the findings of people in their age and say, oh, we could find 40% or plus of people in their 40s have these disc changes here and don't know about it. It's the same equivalent exist for endo as well.
Yes, well, sometimes the diagnosis of endometriosis can be an incidental finding. So a lady goes in for example, a hysterectomy, and that can endometriosis can be diagnosed then,
Yeah.
and she wasn't aware of it. Or sometimes she's not aware she's got endometriosis, but she perhaps goes in for uh, some sort of infertility investigation,
Mm.
and that can be found as the cause. Yeah.
Ah. As you say, different people in different ways.
Yep.
Um,
Yep.
and
And
we
a
always know
lot of
why.
it to do with their nerve sensitivity as well.
Yeah.
Yeah. And that's why giving them a really good pain science education can be really helpful.
I'm making an assumption because we sometimes get this with changes and scans and people's beliefs. Are there times when someone may feel that unless they get it removed surgically, that it can't get better or it can't be like they can't manage? Does that happen?
That is sometimes the case. Yes, if you've got really significant deep disease, then yes, it absolutely must be removed. Yeah. And
How
sorry, yeah.
how do you manage that when someone's saying, I've got this, I'm not going to be able to get better unless this is removed. But there's things that we'll come on to about things you can do to help and suggest. And there's various options for endo beyond just surgery. Um, but they're very focused on this has to get out of me until and I can't get better. How do you kind of manage that when their focus is very much on surgical?
Yep. For some women, they will not be appropriate for surgery. Perhaps their BMI is too high. Perhaps they are trying to conceive. Perhaps they just have other conditions like severe hypertension, and they're just not a surgical candidate. And that sometimes can be the reality. But ideally, deep disease, certainly, or even superficial disease, is surgically removed by an endometriosis specialist. However, for some women, hormonal suppression, so being on, the oral contraceptive pill or the Mirena coil, an IUD, can be useful to help manage their symptoms, but that endometriosis doesn't magically disappear.
No.
It's a difficult situation because we know the reoccurrence rates of
Mm.
endometriosis are high. It's between 40 and 50% of reoccurrence rate at 5 years after specialist excision. So that in itself is quite tricky, but certainly no surgeon, specialist surgeon worth his salt is going to reoperate within 6 months. And
Oh.
sometimes patients have had specialist excision surgery and they're still in pain. 40% of women who have even specialist excision surgery will have continuing or persistent pain. And that can be really difficult because they've put all their eggs in one basket. They are
Yeah.
desperate for surgery and they can feel really let down. Like they're in limbo because they feel they can't do anything, although they can with pelvic physio.
Yeah.
But they can feel so disappointed after surgery. Well, why am I still bloating? Why have I still got this pain? And
Mm.
sometimes it can be to do with the pelvic floor muscles, which we can help with.
Yeah, of course, of
And
course.
that nerve sensitivity, that upregulated nervous system.
And without without turning this into a pain podcast, is there anything when you come to that conversation and they say, I've had the surgery, but I'm still in pain, is there anything with endometriosis or especially with pelvic pain that you feel you need to add or change in certain ways to a more generic, if I call it explain pain spiel, or helping them understand it that you do for this specific clientele?
For this specific clientele, an awful lot of pelvic physio can be to do with explaining sexual pain,
Ah,
why they have sexual pain.
mm.
And
We're
that
just
can be to do with the exact location of the lesions and the tissues getting irritated with deeper penetration, or the experience of sexual pain then causing that involuntary spasm of the pelvic floor muscles. So it's so yeah, a lot of what we do is helping that kind of sexual pain,
mm.
yeah,
Does it
sexual
come
pain re-education.
does it
Or
come up naturally in conversation when you're finding out about someone's pain and their endometriosis and their journey and how it's affected them? Will that naturally come out by itself?
yes, yeah,
Okay.
I would say that's certainly been my experience is that they're there for pelvic physio, and I will have gone through how the pelvic floors are highly emotionally sensitive muscles and the experience of pain, how the pelvic floor muscles are in such close proximity to the endometriosal lesions, how tightly packed the pelvis is,
Mm.
and it tends to, that conversation does tend to happen naturally. But if it didn't, I would very much use the kind of implicit, so permission, limited information, specific suggestions, intensive therapy. So asking, is it okay? Normalizing conversation and
Yeah.
not asking them for that permission. Is it okay that we talk about sexual pain? We can talk about it generally. We don't have to talk about your particular sexual pain. But most patients, they're there for pelvic physio. You've built that therapeutic trust and alliance. So sometimes it can be a relief for them to say, I find sex really painful, or, you know, I've never had pain-free sex. And
Really?
that's a big admission. And
Yeah.
that's the reality for some patients
Wow. Never
because of the
pain-free.
endometriosis. Yeah.
Wow. I guess again, because it's the area in the body part and how it is it ever something you have to almost feel you have to raise to ask, or or it just will just come out by itself naturally as they start talking about, how it affects their life and
Yeah, it generally just does come out. And yeah, yeah,
where do you sit with that? Especially someone saying, I've never had pain-free sex.
yeah, that's not entirely uncommon
Oh,
in endometriosis. Yeah. And sometimes that's something that they will discuss with one another, and it's almost
oh,
competing with each other. How, it's more painful for me than you. Yeah. Endometriosis pain is so variable. Some people will describe it as burning, tugging, sharp,
mm,
shooting, numb, radiating. Some will say that classic in the endometriosis community is that sharp, shooty bum pain.
mm.
They
Yep.
say, "Oh, I've got that worse than you," and or pain after sex, or even pain with arousal. So it's
Yeah.
really, it's tricky, it's sensitive, and you really have to use that trauma-informed approach. So very much establishing safety, trust, choice, collaboration, and not pushing the patient. So everything is very at, at their pace. And very often they're aware that pelvic physio can involve internal examination, internal treatments,
Mm.
but they can have this real fear of, I can't tolerate spectrum examinations. It's so painful. So they can have that real fear of pelvic physio. And so we say, absolutely, you're in control. We're not going to hurt you. The last thing we want to do is cause you more pain. Endo's painful enough.
Absolutely. How do you have interest is whether well, let's say someone who's still got their endometriosis, let's say it's not been surgically removed,
Yep.
whether it from a pelvic physio perspective, how do you almost, I want to say sell it, if that's the best way to phrase it, but like, help them feel that what you're going to be going through will be a benefit. You're not removing the endometriosis is there, but what you are going to suggest and hopefully go through with them as part of a shared decision making process will help. How do you help them kind of, I would say, buy into that?
It's a very holistic biopsychosocial assessment that we do,
Mm,
and it's very multimodal. So we use lots of different tools and strategies, advice about self-management, lifestyle management, pain control. We are big advocates of TENS, of showing them how to do abdominal self-massage for the bloating,
mm,
treating them, explaining to them about how their bladder and bowel are affected, get them to do self-release of their pelvic floor muscles, vulval massage, it's very broad what we do,
Mm.
but it's very individualized on what that endometriosis patient is presenting with. They can come in with this perception of what we're going to do, but it's very much about looking at them holistically and helping them build up their self-care strategies.
And as you say, kind of meeting them where they're at, where it's comfortable for them.
Absolutely.
Um,
And being kind of culturally sensitive as well. So for some
ah,
of the Asian ladies that I see,
yeah.
I'll talk generally about painful sex and not specifically about their sexual pain.
Mm. Interesting. Any other cultural changes you may make for not just Indian, but any
I think
different?
sometimes age sensitivity can come into it.
Okay.
Yeah, the younger clients might prefer a younger physio, perhaps. And some of the older ladies might, in pelvic health generally, might prefer an older physio. I
Mm.
suppose it's just how you approach it.
Interesting. Okay. Were there things you wanted to say about conversations with endometriosis, whether it's related to setting expectations, surgery, and helping them understand it, that we've missed, that you think is important?
We were talking earlier about the importance of prehab. So
Mm.
before surgery to get the patients in the best physical fitness. So, eating well, sleeping well, exercising well before surgery, and having pelvic physio before, so they have an understanding of the pelvic floor muscles and the post lap rehab is also really important. So after surgery that they come to us so that we can, make sure they're continuing to make that progress. But endometriosis patients often have a lot of comorbid pain conditions like polycystic ovaries, fibromyalgia, adenomyosis. So that's adenomyosis is they describe it as kind of a heavy burning bowling ball. So that is where there is endometriosis in the muscular lining of the womb itself. So it's distinct from but associated with endometriosis. Heavy menstrual bleeding and passing clots is what you would get with adenomyosis, and often you'll see endo with adenomyosis as well. So there's a lot of comorbid pain conditions, and that can just contribute to the heavy loads that endometriosis is. Yeah, and obviously the PCOS can also affect fertility. I think my only other point is just that many endometriosis patients will have persistent pelvic pain due to the chronicity, how long they've had endo, and often it does start as cyclical, 5, 6 days of the month, and then it becomes continuous.
Mm.
And that can be such a heavy load for these patients, and that contributes to the kind of helplessness that they can feel. So when I assess a patient, I will often use Caroline Van Dyken's Sadcliffe's. So, Sadcliffe's, so stress, anxiety, depression, catastrophizing, low self efficacy, low self affect, injustice, massive,
Yeah.
fear, shame, sensory motor dysregulation. So I'll often have that as part of my framework in assessing where is that patient.
You said about injustice. I think injustice is one of the unspoken ones. People pay a lot of attention to your catastrophizing, your fear avoidance, your
Yeah, yeah.
self-efficacy even these days. Um, but injustice, especially, I think it's an unspoken one, but can be particularly powerful and impactful, depending on obviously the individual and their story. But why this happened to me? Why this? I haven't done. I've lived a good life. I've been healthy, but I've got this now.
Mhm,
I don't deserve this. I think it's it's we're unspoken about, but often can play a massive part in someone's journey.
Yeah, yeah,
Out of interest, I was thinking as you were saying there about the different types and conditions that come with it. We were talking earlier about causes, and I know this wasn't our little plan, but if someone was to ask, is this passed down or is it genetic? Um, what should we
yes,
say? Yeah.
there is a strong genetic predisposition, so you are much more likely to have endometriosis if your mother or your sisters have
Mm,
it. So first line relative, yeah,
interesting. Okay.
yep,
Not, I
and
presume
that's
it's not a
to do with
guarantee.
that. Not a guarantee, but much more likely. Yeah,
Mm,
much more likely. And again, that can be contribute to the delay because you hear from your grandmother and your mother that periods are very painful. They're heavy, you often pass clots, and that becomes normal that you have really severe menstrual cramps because that's what your grandmother said her periods were like, and your mum. Yeah,
mm. And they just never got it seen to.
yeah, but
Mm,
heavy and really painful periods are absolutely not normal.
mm.
Yeah, and we shouldn't tolerate it. We need to get that message out as when you know, and it needs to be part of that education in schools. What's a normal menstrual cycle?
Is awareness getting better?
Yes, very
Yeah.
definitely getting better. Yep.
Seems to be, certainly what we were saying earlier, talked about it more than it was in the past. I can't remember even 5 years ago, the people in the general public on TV, audio, podcast, whatever, meant talking about endometriosis much, if at all. Um, Now, from my perspective, not that I'm an expert at all, but I can see it talked about more. Um, like
Yeah.
mental health, I guess, isn't it? Other things like that.
And I think that's a good thing that we're breaking down these taboos and barriers about talking about menstruation when it's such a natural process.
Mm.
More than 50% of the population will menstruate at one time. And I think some of that is to do with kind of high profile celebrities. Very recently, Ella Henderson, who was in X
X
Factor, I
Factor,
think,
yeah, I think so.
came out on social media and explained her endometriosis journey. And I think that was really positive.
Mm.
Yeah.
So, what's been one of your hardest clinical conversations?
Okay, I told you I've had various different answers for that, but I think my most memorable, hardest conversation was when I was working in palliative care.
Mm.
And that was a number of years ago, and I was treating a lady in her 80s who had ovarian cancer. And just conversationally, I said, Did you never get married? And totally unexpectedly, she disclosed that she'd been abused as a child in children's homes and just explained that she'd never told anyone this before. And it was such a detailed narrative. And I remember I was pregnant at the time and I had two little ones at home. And the conversation really just stayed with me. And I was really affected by it. I just thought, did I say the right thing? Where did that come from? And I certainly asked the lady, did I have permission to share some of that conversation with the nursing staff? She did get support, but I think it just highlights that physios, we don't get communication training in how to handle these sensitive
Mm.
disclosures. And just how that of vicarious trauma, it's still trauma and it can stay with us. And just the real crucial importance of really embracing and understanding trauma informed practice.
Absolutely.
Yeah,
I completely agree. Since having children, certainly whether it's when someone says something or you see something on TV or read, yeah, it does
yeah.
hit a lot more.
Uh-huh.
It's more of
And I debriefed with the nursing staff and about that lady, and they said it's not entirely uncommon at that end stage for patients just to feel that they need to offload and trauma dump or
yeah,
disclose something really significant. And yeah, just really, for me, it was a real push. I really do need to learn about trauma-informed practice and how to kind of reflecting on, did I handle that conversation well? I would certainly be able to handle it a lot easier now.
yeah,
And certainly in pelvic health, it's not entirely uncommon for us to get those kind of disclosures just due to the intimate nature of the work we do.
yeah,
Yeah,
yeah. It also says something about the rapport and relationship you built with that person that they
yeah,
felt after 80 years.
yeah.
How long have you been speaking to them for that you were the person they wanted to tell?
Mhm.
Um, and I guess this could happen
And
to all.
she certainly, I said to her, how does it feel to have shared that with me? And she said it was just such relief, but she had such regrets that she hadn't come forward earlier. And yeah, life's precious, and yeah.
Absolutely. It's and this could happen to anyone, whether in palliative care or pelvic health or persistent pain or GP or
Mhm.
wherever you are. If it's the right time for the person and you've built up the right relationship and it might come out.
But yeah, it stays with you.
It does do. Yeah, absolutely. Yeah. And I
Give,
always,
give me your bit on that.
well, I will always say, whether it's childhood stuff or an adult, and doesn't have to always be sexual, it could be some other trauma.
Mhm.
Um, you sit there, you let them, they'll say, as we've said earlier, sit in the mud, so to speak, as best one can. I always say, I'm grateful for you telling me. Would you what help have you had, or would you like some support with this? Um,
Yeah.
or what, sometimes actually asking what support doesn't, because sometimes you say, who do you want to talk to, makes it sound like you need to go talk to a psychologist about this. Well, support might be friends, support may be family members, maybe whoever.
Mhm.
Some people
Mhm.
find that much more comforting than having to go to speak to the professional.
Yeah.
Um,
And I think what is really important is that we acknowledge the courage it is taken for someone to disclose, and it's a it's a privilege and a
yeah,
responsibility that they've demonstrated that trust in you, and that you're that kind of holding that safe space with them, and just be sincere and authentic, and to say, it's not about you, but I'm sorry that happened. That sounds really tough.
yeah, 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 absolutely. Um, and ultimately down to them what they want to do and be back with it. It may be something they've actually had a lot of help with already and don't need to revisit it. They may not want to. It's completely in their court ultimately. But it can, as you said earlier, it can happen to any of us at any time because you just never know. But we'll end this on a more positive. So, what's on the flip side of that? What's been one of the more memorable successes with someone with endometriosis that you've had?
So, as many pelvic physios, I've had quite a few endo patients who have experienced really significant vaginismus and sexual pain, and they have struggled with intimacy, and they've come back pregnant or having had a child, and that's just, you know that you have contributed to that. and helping them have, less pain so that they can have sexual intercourse or tolerate going through IVF. So that's a great privilege to be able to do that.
Your
Yeah.
work has literally brought life into the world indirectly.
But that's not unique. That's the many pelvic physios
Yes, yes,
will be able to
definitely.
say that. Yeah.
And I presume also not just brought the life in, but also potentially um, maybe saved or drastically improved a relationship as
Yeah,
well.
absolutely. Absolutely. Yeah, as you said earlier, endo affects that person, but there's that wider ripple,
Yeah,
friends, family members, partners can really be significantly affected by that endo diagnosis. Yeah,
you do a lot of work with Endo UK,
I do.
and people can go onto their website, and is that the main hub for endometriosis information in the UK? Is that right?
Yes, there are. Endo UK is has absolutely high quality resources, and they have a medical board that facts checks all the information. There are local support groups, whether you're in, England, Scotland, Northern Ireland, Wales, and there are in person and Facebook groups, and they're very active on their Instagram live and things, but really high quality resources.
Tell me about the future. What's coming up for future research, or even doesn't have to be in 5 years' time, it could be very soon for endo, and how it might impact on people's future care.
There's lots of exciting research coming out of the University of Edinburgh with the Endo Expect team and Endo 1000. They take all sorts of clinical samples from endometriosis because they're trying to create biomarkers and effectively treat the disease. And there's also wonderful stuff coming out of Oxford University. And Australia also does a lot of research on management of endometriosis. But the bottom line is that multimodal pelvic physio for endometriosis is really impactful.
Absolutely. And hopefully, over time, as awareness increases, as it is,
Yep.
time to diagnosis should come down.
Hopefully,
Hopefully.
hopefully.
Good.
And but I think the cure for endometriosis, particularly because endometriosis isn't just one disease, there's different subcategories, and endometriosis isn't this homogenous condition.
Yeah, absolutely.
So I think we're a wee while away from cure,
Yeah.
but there's lots of really exciting physio-specific endometriosis research coming out. So the
Good.
future is bright.
Excellent. Well, I'll tell you what, we'll end on that positive. Pauline-Clare, thank you very much for your time and willingness to do this.